You can start, Nikita.
Good evening to everyone. A very warm welcome to the ISA National Online Postgraduate Class. These classes are designed to empower postgraduate students with a deeper understanding of anesthesia and clinical practices. I'm Dr. Nikita Vasan, working as a senior resident in anesthesia and intensive care in Vardhaman Mahavir Medical College and Safdarjung Hospital, New Delhi, and it is my honor to serve as a screen coordinator in this session along with Dr. Anupriya. Before moving forward, let us invoke the divine blessings of Ma Saraswati with the Saraswati Vandana. New Delhi, and it is my honor to serve as a screen coordinator in this session along with Dr. Anupriya. Before moving forward, let us invoke the divine blessings of Ma Saraswati, the Saraswati Vandana. Today, we shall be having an interactive discussion on a challenging and clinically relevant topic, perioperative management of tracheoesophageal fistula in neonates. Before moving on, with utmost pleasure, I invite our Honorary Secretary ISA National, Dr. Sukhminder Bajwa sir, to address the audience and share his valuable insights. Over to you, sir.
Thank you, Dr. Nikita. Yes, it's one of the very important topic. Uh, if you go through your standard textbook of anesthesia, one of the most commonly read topic is out of the four topics, this is one, the tracheoesophageal fistula. And when you learn this, the perioperative management, the pre-operative evaluation, and the post-operative care, I think that is the best of your time in your postgraduate career to learn such anesthesia pearls in managing these cases. Because you get a variety of the cases in this TF also, right from the airway management to the anesthesia management and the pediatrics, small kids, sometimes not even 24 hours old or sometimes just 3, 4 days old. So you are managing those young kids, and this is one of the best part of anesthesia. It's a beauty. Small kids who are just coming to the world, you are giving anesthesia to these people, and very challenging. It's a very difficult also sometimes, but I think we people are doing it for a long, long time over the decades, and now with the advent of so much of technology and advancements, things have become little easier, but still it's remain a challenging job to anesthetize such young patients. So it is associated with a lot of precautions, management strategies, so many things are there, which I think will be dwelled upon by a very good team from Jammu today. So they will be dwelling upon this thing. So let's start the proceeding with that. So Nikita, take over from here and please proceed for further. Awesome.
Thank you, sir, for your valuable words. Next, I would like to invite my co-screen coordinator, Dr. Anupriya, to introduce our esteemed faculties for this session, as well as to clarify the rules and format of this class. Over to you, Dr. Anupriya.
Thank you, Dr. Nikita. Good evening, everyone. I am Dr. Anupriya Chaturvedi. I did my senior residency from GMC Nagpur Trauma Center in Anesthesia and Critical Care and currently practicing in Nashik. It's my privilege to take over as a screen coordinator for today's session. I am honored to introduce our esteemed faculty member for today's ISA class. We have with us our faculty coordinator, Dr. Raksha Kundal ma'am. Ma'am is Associate Professor, All India Institute of Medical Sciences, Jammu. She is ex-professor, Lady Hardinge Medical College, New Delhi. Ma'am has special interest in pediatric anesthesia and ultrasound guided blocks, pain and palliative care medicine. Ma'am is ex-ordinary treasurer in Indian Association of Pediatric Anesthesia, Delhi. Ma'am is executive member of ISA Jammu. She is Institute's ethical committee member. Ma'am is a COVID warrior awardee. Ma'am has been awarded with Best Paper Ratna Sabhapati Award Sri Lanka. She has 48 plus publications in national and international journals. Welcome you on board, ma'am, with today's session. Our next faculty moderator is Dr. Renu Vaklu, ma'am. Ma'am is Associate Professor, Department of Anesthesia and Critical Care, GMC Jammu. Ma'am has PG teaching experience of 25 years. She has special interest in regional anesthesia, labor analgesia, obstetric anesthesia, and USG guided blocks. Ma'am has been awarded with Best Paper in North Zone Conference in Shimla 2004. Ma'am is a trained BLS and ACLS provider. Ma'am is a life member of Indian College of Anesthesiologists. She is a life member of GOACP and Association of Obstetric Anesthesia. Ma'am is executive member of ISA Jammu branch. Ma'am has conducted labor analgesia workshop in various conferences. She has been invited as faculty in various zonal and international conferences. Ma'am has number of publications in national and international journals with 2 chapters in the textbook. We extend our warm welcome to both of you and sincerely appreciate your time and guidance. I'm sure this would be an enriching experience for all of us with our well-prepared presentators under the guidance of our esteemed faculties. Before beginning with the session, I would like to share a few important instructions for all the attendees. Please ensure that your audios remain muted and videos turned off throughout the session. If you have any queries, kindly post them in the chat box. These questions will be addressed by our faculty at the end of presentation. Thank you for your cooperation. Now I'll hand over to Dr. Renu Vaklu, ma'am, to begin with the session. Ma'am, please take over.
Thank you, Dr. Anupriya, and good evening to all. I'm Dr. Renu Vaklu, and along with my co-faculty, Dr. Raksha, at the outset, I would like to thank the ISA academic team under Dr. Bajwa for giving us this opportunity to conduct this interesting case of tracheoesophageal fistula. And I would like to congratulate him for carrying on this wonderful initiative forward. And as far as the PGs are concerned, you may not get this case in the practical examination as a long or a short case for obvious reasons. But I'm sure till you're in the residency and post-residency period, at one or the other time, you will be called to give anesthesia to one of these patients. And with the improvement of anesthesia techniques, the NICU services, then the surgical techniques, you may be called to give anesthesia because these patients stay on for a longer time. So you may be called to give anesthesia for related or non-related surgeries also. Therefore, it is a very relevant topic for all of you. And the case will be presented by Dr. Taiba, who is a third-year resident in GMC Jammu, and Dr. Medha, who is a registrar at AIMS Vijaypur. Over to Taiba.
Good evening, everyone. So, ma'am, the topic of my presentation is tracheoesophageal fistula. So, I'll start the case now. In my case, In my case, the informant was mother, 24-hour-old, 36-week baby weighing 2 kg, was presented with complaints of choking over feeds, coughing and respiratory difficulty following every feed. The birth history was that the baby was the first child to a 28-year-old female who conceived naturally but had a history of polyhydramnios and gestational diabetes, diagnosed during her first visit to the hospital at 35 weeks, born via vaginal delivery in a peripheral hospital. Mother had no history of drug intake or infection. Attempts to place nasogastric tube by a pediatrician were unsuccessful, so an X-ray was done, which showed coiling of the tube in an esophageal pouch. The patient was diagnosed with tracheoesophageal fistula and was referred to a tertiary center where he was admitted in neonatal ICU. On head-to-toe examination of the baby was lying prone with IV infusion of D10 and intermittent oral suctioning being done, frothy secretions around the mouth. Baby was on nasal prongs, maintaining saturation of 90% in right hand and heart rate of 134 per minute. Tachypnic with respiratory rate of 50 per minute with subcostal retraction. Skin turgor was normal. Capillary refill time was less than 2 seconds. Anterior fontanelle was not depressed. Eyes normal. Normal set ears. Nasal corner normal. No cleft lip or palate. Limbs were bilaterally symmetrical. Abdomen appeared little distended. Genitalia normal. No anal atresia, and child was passing urine as assessed by his diaper. On auscultation, chest bilateral crypt present. Normal heart sound with systolic murmur. Lab investigations were done. Blood investigations. On complete blood count, the hemoglobin was 16 gram per deciliter. There was leukocytosis 16,000 per mm3. Electrolyte sodium was 138 milliequivalents per liter. Potassium was 4.2 milliequivalents per liter. On ABG picture, pH was 7.36. PCO2 was 48 mm of mercury. PO2 was 88 mm of mercury, and bicarbonate were 28 millimoles per liter. The blood group of the baby was B positive. Chest X-ray of the baby was done. The nasogastric tube was found coiled in the upper abdomen, thorax, in the upper thorax. On echocardiography, there was mild tricuspid regurgitation, patent foramen ovale, 1.2 mm, with small left to right shunt. Other investigations to be done are random blood sugar, renal function test, ECG to rule out QT and other rhythm abnormalities, USG KUB to identify anomalies, and also MRI spine. Some summary of the case is that 36-week-old baby weighing 2 kg was presented with complaints of choking over feeds, cough and respiratory difficulty following every feed. No associated visible anomalies, inability to pass the nasogastric tube, and after confirmation with X-ray, the child was diagnosed with tracheoesophageal fistula and referred to our center.
Okay, Taiba, so you have presented the history and examination and investigation. So according to you, the diagnosis is tracheoesophageal fistula. You already know the diagnosis, right?
Yes, ma'am. Yes, ma'am.
What is tracheoesophageal fistula?
Ma'am, tracheoesophageal fistula is an abnormal connection between the esophagus and trachea, whereas esophageal atresia is the discontinuation of the esophageal opening from pharynx to the stomach.
Right. So what is the pathogenesis of the condition? Why does it occur?
Okay, ma'am. Normally, what happens is that during development, in the 4 to 6 weeks of gestation, there is separation of the from the primitive foregut of the trachea and esophagus. But in case of tracheoesophageal fistula, there is incomplete separation of the two. From the trachea, there is incomplete separation, resulting in abnormal connection between trachea and esophagus. That is the abnormality that occurs in this, ma'am.
Right. So the fate of the child is decided at 6 to 7 weeks intrauterine itself, right?
Yes, ma'am. Yes, ma'am.
What is the prevalence of the condition?
Ma'am, the prevalence is around 1 in 3,000 neonates, whereas it is seen more in males as compared to females.
Good. So what are the types of tracheoesophageal fistula that you know of?
Ma'am, there are ma'am, two classifications are there to divide, ma'am, the tracheoesophageal fistula. There is gross classification and there is Vogt classification. Ma'am, in gross classification, we have 5 types: A, B, C, D, and E. Ma'am, in A, there is isolated esophageal atresia. In B, there is esophageal atresia with proximal TEF. In C, there is esophageal atresia with distal TEF. In D, there is esophageal atresia with proximal as well as distal TEF. Whereas in E, there is isolated TEF, which is also known as H type of ma'am, TEF.
You can call it H type or N type, any of the two, right?
Okay,
So
ma'am.
you can see from the figures, I can repeat again for the PGs. In the type 1, what do you see?
Ma'am, in the type 1, we see isolated esophageal atresia, ma'am.
There's absolutely no communication between the two
Yes,
ends.
ma'am.
That means the lower end of the
Yes,
esophagus
ma'am.
is blind. So that is not communicating with the trachea. So there will be, what will happen to the air in the stomach?
Ma'am, there will be no air.
No air in the stomach.
Yes, ma'am.
What about type 2, type B? Again,
Ma'am, in type
lower
B,
end
yes,
is
ma'am.
blind. So again, there'll be no air in the stomach. Well, in the other
Yes,
three,
ma'am.
because the lower end is communicating with the trachea, so you will find gas in the abdomen. That is a differentiating feature, right?
Yes, ma'am.
Okay. Now the
Dr.
MCQ question.
Taiba, can you make it full screen, please? On the right
Yeah.
lower hand side, yes, niche.
Is it okay now?
Yeah.
Okay. So is it clear? So in the first two, you will not have gas in the abdomen because the lower end is blind. Whereas in the other three, because it is communicating with the trachea, you will find gas in the abdomen.
Yes,
That is one of
ma'am.
the differentiating features.
Yes, ma'am. That is a differentiating on X-ray, ma'am.
Okay. Now, can I ask an MCQ question to the PGs, which is the most common of the three of the five you encounter, and which is the least common? Anupriya, will you coordinate? Will anybody answer?
Yes, ma'am.
Which one is the most common and which is the least common?
Students are answering C as the most common.
Yes. The incidence is around 85. More than 85% will be type C. And least common is?
Least common, H is least common. They have
Type
answered.
C is
One
least
of
common,
us.
1%. The incidence is 1%.
Yes.
Okay. Now coming back to history, Taiba, will you go back to the history?
Okay, ma'am. Yes, ma'am. This is the history.
You have talked about polyhydramnios. So
Yes, ma'am.
what is the importance? What does it strike in your mind when you read this term polyhydramnios, the female presented with polyhydramnios?
Yes, ma'am. In case of a deaf baby, what happens is that the baby in the womb cannot swallow the amniotic fluid, which results in polyhydramnios. So as a result, it is one of the antenatal finding that we see, polyhydramnios, ma'am.
Yeah, very true. Because the baby cannot swallow, so
The
there be
there
fluid,
is accumulation. Yes, ma'am.
accumulation of fluid, and the incidence of polyhydramnios with TEF is to the extent of 60%, right?
Mm.
So then you talked about she had a normal, she conceived naturally.
Ma'am.
What is the importance of mentioning this over here?
Yes, ma'am. What happens is that TEF is most commonly seen in babies born to females who conceive through IVF. So IVF is one of the risk factors for TEF, ma'am.
Okay,
So
so
that is why I just mentioned naturally.
good. So what are the other risk factors which are associated with TEF?
Yes, ma'am. Other risk factors are uncontrolled diabetes mellitus, elderly female, certain drugs like methimazole or diethylstilbestrol, um, and consumption of alcohol or smoking, history of smoking. These are the risk factors, ma'am.
Factors, good. So how can you make the prenatal diagnosis in these patients?
Ma'am, in the prenatal period, since there, we can rule out polyhydramnios is one of the things from which we can rule out TEF. Also, ma'am, if USG abdomen is done, we can see there is absence of stomach bubble on USG, ma'am. That is also one thing that will.
And you might also find a dilated esophageal pouch. So these
Okay,
three
ma'am.
things
Okay.
will clinch the
Will be
diagnosis.
seen in the prenatal, yes.
And postnatally, you can see from clinical manifestations. So what were the clinical manifestations in your child?
Ma'am, in my case, the clinical manifestations were choking over feeds, coughing and respiratory difficulty following every feed.
Right. So this is a very clinching evidence that the child
Yes.
has some problem in
Hmm.
the gut and respiratory tract. Now, can you tell me, this is a question for the PGs again, what are the 4 C's in the clinical manifestations that can help you arrive at the diagnosis? There are 4 C's, the clinical manifestations. Anupriya?
Yes, ma'am. Waiting for answers.
I think we should repeat question again, ma'am.
Question is, what are the clinical 4 C's of the clinical manifestation that help you arrive at that you think that this could be tracheoesophageal fistula, the clinical manifestations in the history, say.
Yes, ma'am. One person has answered.
Yes.
Choking, cyanosis, and coughing.
And the fourth one? The 4 C's. Good, that's good.
One has answered crepitus.
No. Crepitus is not a clinical manifestation.
Yes.
Coughing, should I answer?
Yes, ma'am. Copious secretions.
Okay,
This
either copious secretion or continuous drooling of secretions. So, choking, coughing, cyanosis, choking over each feed, right? Coughing, cyanosis, and continuous drooling of saliva. So, these are the 4 C's of the clinical manifestations which will alert you to the diagnosis. Okay, now coming back, Taiba, any other way you can postnatally, you can detect this condition?
Yes, ma'am, through an X-ray. Like if we get an X-ray done, we can see the
X-ray of
coiling
what?
of the feeding tube. Yes, ma'am.
What X-ray?
Like we have the X-ray of our neonate as well that we had.
Oh, X-ray of what part? The hand?
Ma'am, abdomen, ma'am. Just an abdomen, ma'am.
Okay. So
Mm.
which view do you take in these babies? AP or PA?
Yes, ma'am. Ma'am, which view? AP view, ma'am. AP view, ma'am. Yes, ma'am.
So what do you see in the X-ray?
Ma'am, in the X-ray, we can see coiling of the feeding tube in the upper thorax because of the atresia, ma'am.
Yes. So this is a classical sign that you see. The tube
Yes, ma'am.
coiled in the upper
Upper
esophagus.
thorax, yes, ma'am.
Exactly. And you can see something else also below.
Yes, ma'am. We can see there is a gas below the diaphragm, ma'am.
Yes, there's gas
In
below.
the X-ray only, yes, ma'am.
So most likely this is
This
what
is,
type?
ma'am, type C, D, or E.
It is not A
C,
or B.
C.
It cannot be A or B,
Yes,
right?
ma'am. C, C, D, yes, ma'am.
Now let's get back to the history again. You talked about the weight of the baby. What is the
Yes,
weight of the
ma'am.
baby?
Ma'am, the weight of the baby is 2 kgs.
The baby is 2 kgs. So is there any importance of weight in these patients and in neonates otherwise also?
Yes, ma'am. The importance of weight is there in this also because it helps us in risk assessment, prognostic assessment of the baby, ma'am. Preoperative assessment, we do it for
Are there
TEF, ma'am.
for that? What
Yes, ma'am. There are certain classifications for that also. Watterson classification, ma'am.
Okay, what is it?
Ma'am, in Watterson classification, there are 3 categories, type A, B, and C. Ma'am, in this, we take 3 things. We take the birth weight of the baby. Ma'am, we take the pneumonia and we take the congenital anomalies. Ma'am, in A, the weight is 2.5 kgs and the survival rate is around 100%. Whereas in type C, the weight is taken as 1.8 kgs with severe pneumonia and congenital anomalies, survival rate of 35%. And this is the Watterson classification.
For the other one?
Ma'am, other one is Spitz classification. This is also divided in 3 categories, but the weight is different from Watterson. In this, the weight is 1.5 kgs, ma'am. And other thing is cardiac anomalies, ma'am. In this, these are the two parameters that we look for.
So any other classification that you know of?
Ma'am, there is one more classification, latest classification, which is Okamoto classification. It has 4 classes, ma'am, 4 subclasses, which are divided into 4 groups. Low, moderate, relative high risk, and high risk. Ma'am, in this also we take 2 parameters, birth weight of 2 kgs, or we take the cardiac anomalies In first, there is no cardiac anomalies and birth weight is 2 kgs, whereas in the last one, high risk patients have a birth weight less than 2 kgs, but they have associated cardiac anomaly.
Okay, good. So can you go back to the SPIDS classification?
Yes, ma'am. So the SPIDS classification.
See the difference. The initial classification was Waterston's classification, where weight was a very important parameters, right? They wanted babies about 2.5 kg for 100% survival. But gradually, as things improved, the mortality came down with better conditions, better NICU facilities, better surgical techniques, better equipment, better anesthetic techniques. The mortality came down. So birth weight now, in group 1, the birth weight more than 1500 survived as good as that in Waterston's classification. Right. So
Yes, ma'am.
after this, so now, in fact, now what they say is birth weight is no more an independent predictor of mortality and morbidity. Right. So now what they say, and there's the latest is the Montreal classification. In that, they say there is 2 parameters that are important. One is the need for mechanical ventilation, and the other is the major cardiac anomaly. In fact, major cardiac anomaly is the most important risk factor for mortality. Did you get my point?
Yes, ma'am.
Now it is need for, if the child has need for mechanical ventilation and has a major cardiac anomaly, he goes in the high risk category. Right?
Yes, ma'am.
Go back to the history again. What is the gestational age of your child?
Ma'am, the gestation age of the neonate is 36 weeks, ma'am.
He's 30. So is he term or preterm?
Ma'am, we take less than 37 weeks as preterm, and in our case, it is 36 weeks, so it is late preterm, ma'am. We take it as late preterm.
So can you, because it's an entirely different topic of discussion, but can you tell me a few important things of anesthetic importance when you anticipate the case of a preterm baby? A few things of anesthetic importance, which you must always keep in mind.
Ma'am, in case of preterms, as the preterm babies are more prone to apnea, ma'am. They are more prone to apnea. They are more prone to hypothermia. They are more prone to hypoxia due to high. Yes, ma'am.
You call it apnea. What is it known as? The term is apnea of preterm. Apnea of
Preterm.
prematurity or preterm, right?
Yes, ma'am. Yes, ma'am.
How many weeks post-conception do you take these patients to be susceptible to this apnea?
Ma'am, around 55 to 60 weeks, I think.
Usually 44 to 54 weeks post-conception. So if your child, this is 36 weekers. So 44 minus 36 will make it how much?
44 minus 36 will make it
8 weeks more, right?
8 weeks more, ma'am.
2 months. So for next 2 months, this child will still remain susceptible
More
to
prone to apnea.
apnea of prematurity, right?
Yes,
Okay.
ma'am.
What are the other things that this child will be prone to? You said hypothermia.
Yes, ma'am. Hypothermia. And ma'am, more prone
Why
to,
are they more prone to hypothermia?
ma'am, their thermoregulatory system is not yet developed, ma'am. Not that maturely developed. Thermoregulatory center of premature infants.
Is it the reason? What happens to the skin in these babies?
Ma'am, skin shivering.
Sorry? Any
Yes,
problem
ma'am.
with Any problem with the
Yes.
skin? Insensible loss? What happens? The skin is very thin. So insensible water loss is higher in these kids, neonates, as
Okay, ma'am.
compared to term.
The
babies.
term units.
Secondly, what happens to the surface area?
Decreased, ma'am. Decreased surface area in preterm or
Decreased or increased?
increased in preterm. I'm not sure about thermoregulatory.
Surface area to body weight ratio is higher in these babies. That is why the loss is more. And lastly, the shivering thermogenesis is absent in these babies. Right?
Mm.
So that is why they are more prone to hypothermia. What other things? Quickly, just a
Ma'am,
few.
these babies are also more prone to bradycardia, ma'am, because their parasympathetic system is more developed than the sympathetic system, ma'am.
Okay, good. Okay, now let's go back to the examination. The history is over, the examination.
Yes, and this is the examination. Yes, please.
Okay. So you said you have done a head-to-toe examination of this patient, right?
Yes, ma'am.
Why do you do a head-to-toe examination?
Ma'am, we do a head-to-toe examination because these babies have associated anomalies as well, congenital anomalies. Yes, ma'am, they have associated anomalies. So we do head-to-toe examination to rule out those, ma'am.
Like
Ma'am,
anomaly.
they have associated vectoral and charge syndrome, ma'am. They have associated vectoral and charge syndrome, ma'am.
What is that?
Ma'am, in vectoral, the acronym for vectoral is V is for vertebral anomaly, A is for anal atresia, C is cardiac anomaly, T is, ma'am, tracheoesophageal, E is esophageal atresia, R is renal anomaly, and L is limb malformations, ma'am.
So initially it was Vater. Then later they added C because again, as I told you, the mortality is maximum because of cardiac problems. That is why, so cardiac C was included in this. So vectoral is, so you have to look for all these anomalies, the vertebral anomalies, you have to look for anal atresia, the tracheoesophageal fistula, esophageal atresia, renal anomalies like, what are the renal anomalies you can expect in these?
Ma'am, single kidney or renal agenesis, we can see hydronephrosis, also posterior urethral walls, ma'am. These are the things that are seen.
Good. And what is the other syndrome?
Ma'am, other one is charge syndrome, ma'am. In this, C is coloboma of the eyes.
What is that?
H is,
What is coloboma?
ma'am, coloboma is, ma'am, incomplete development of the eye tissue. Yes, ma'am.
Iris.
Iris, ma'am, iris. H is heart defects. A is atresia corner. R is retarded growth. G is genital anomalies, and E is the air anomalies.
Right. So what heart defects are most common in these babies?
Ma'am, in tracheoesophageal fistula, the heart defects that we see most commonly is VSD, ma'am. Ventricular septal defect most commonly seen.
What is the percentage?
Ma'am, I think
First, tell me what is the incidence of associated abnormalities in patients with tracheoesophageal fistula? What are the other abnormalities, the percentage?
ma'am, other associated, ma'am, first of all, we have cardiac anomalies that the incidence is around 30 to 35%.
Total incidence of associated.
Ma'am, overall, congenital anomalies, there is 50% around, incidence of 50% around, ma'am, congenital anomalies.
Good. So around 50% of them have associated anomalies, right? And of the heart defects, the most common you said is VSD. After that?
Yes, ma'am, after that, we have ASD, ma'am.
ASD, and then?
Ma'am, TOF, tetralogy ma'am, then we have.
Okay. So what is the incidence of heart defects?
Ma'am, overall incidence is around 30 to 35% of heart defects in these patients, ma'am.
Good. Very good. Any other syndromes which are associated with tracheoesophageal fistula?
Ma'am, yes, ma'am, there are limb anomalies like radial ray hypoplasia.
No, I'm
That
asking
limb
about
anom-
syndromes. Limb comes in vector only, na? Vectoral.
Okay, ma'am. Other, ma'am.
Any
Ma'am, the short stature or micro.
any genetic association?
Yes, ma'am. Yes, ma'am. There is genetic association also. Ma'am, like trisomy 13, 18, and 21, ma'am. That is the genetic association with seen with deaf babies.
21 is which condition? What do you call 21? Trisomy 21 is?
Ma'am, Down syndrome.
Okay. Right. Okay. Then you have again go back to examination. You said you have put the child in the prone position.
Yes, ma'am.
Why do you put the
Yes,
child?
ma'am.
Why do you put the child in the prone position?
Ma'am, deaf babies are at more risk of aspiration, ma'am. They are at more risk of aspiration, so we put them in prone position or lateral position. Ma'am, nowadays we also put them in a 30-degree upright position with continuous suctioning, ma'am. That is what we do nowadays.
Okay. So you can put them in semi-prone also, not necessarily
Yes.
either semi-prone or upright, 30 degrees upright, you can put them. Okay. Then coming to, okay, go to the investigations. So just a minute. You talked about the prognostic factors of the weight, right? Because mortality was associated with weight. Any other thing, importance of weight in small children in neonates? Any importance of weight? Otherwise, besides this case.
Ma'am, for us also it is for we decide the placement of endotracheal tube also.
Weight.
For ma'am, airways.
Think. What will happen to the airway? One side will be smaller, one side will be larger with weight.
Ma'am, we
Nothing to do with dehydration. I told you insensible losses are very high in preterm babies.
preterm babies, ma'am. Yes, ma'am.
Have anything to do with dehydration? What happens to the babies after birth? Neonates, what happens to them? What happens to the weight after birth, rather? The initial few days, what happens?
Ma'am, it increases in the initial few months, no, ma'am, weight of the baby's initial months.
Why will it increase? Initially, there is diuresis. What has happened? The pulmonary vascular resistance has reduced. So
Ma'am,
blood is now
HPV
coming
has
to the atrium and ventricles. So there is release of atrial natriuretic peptide. So with that, what will happen? There is loss of salt and water. So initially there is diuresis, right? So you have to check the weight every day for these babies, and any day a weight loss of more than 2% means the child might be dehydrated, and you have to look for other signs of dehydration then. And before surgery, you have to replace that loss. That is why we check the weight every day, right?
Okay, ma'am. Yes, ma'am.
Okay. So your baby, everything was okay. Skin turgor was normal. Capillary refill was. How did you check the capillary refill?
Ma'am, we ma'am, we just uh, press the skin of the baby, ma'am, for like a few seconds, ma'am, and then we release our finger and we see for the we see for the discoloration to come back.
Where do you press?
I'm on the in units we see on the chest,
Sternum or
chest, ma'am, sternum or
forehead?
head. Yes,
Okay.
ma'am.
Go back to the next slide. Turn on the slide. Next, the investigation.
Investigation.
Okay, you did an echocardiography of this patient. So any other particular thing you want to see in the echocardiography that will alter the surgical technique?
Yes, ma'am. If the baby has associated cardiac anomaly, ma'am.
So how will it change the site
Ma'am,
of?
then we have to repair the cardiac defect as well, ma'am.
I'll give you the hint. The site of incision will change.
Yes, ma'am. Yes, ma'am. Ma'am, in case of if the baby, ma'am, they can have right-sided aortic arch, ma'am.
You can have a
Huh.
right aortic arch.
So, ma'am, if
How
they
many
have,
percentage? In what percentage of patients it is present?
ma'am,
0.5. It
I'm
is
not I'm not sure of. Yes, ma'am. Okay, ma'am. Right-sided aortic arch. Yes, ma'am. Ma'am, if the baby has right-sided aortic arch, then the normal approach that the surgeon approaches is the right-sided thoracotomy. But if the baby has right-sided aortic arch, then he'll approach from the other side, from the left side. He'll approach from the left side. Left-sided thoracotomy will be done.
good. So the history examination part is over. Now I have a few questions for the PGs to answer. I hope they're not sleeping. So let us put those questions to them.
Yeah.
Wait, can you post that slide, please? Okay, so this is a tube. Can anybody name what tube is this? I've taken two pictures of the same tube. The hint I can give you that has two openings. One is the blue, you can see the blue port on one side and white one on the other. Am I audible? Am I audible?
Yes,
Yes.
ma'am. Yes, ma'am, you're audible.
Okay, so what is this tube? Another hint I can give you is that it is for suctioning. Anybody knows the name of this tube?
A student has answered Ripogal tube.
Oh, great. Good. Who is that student? You must clap for him. Sir, is there any prize for the best answer?
Two of
How
them
much
have
you want to give?
answered.
How much you want to give?
कौन बनेगा करोड़पति, sir?
नहीं, how much you want to give?
So I'll give whatever you say, sir.
Okay, we can give. Surprise, let it be a surprise only.
Okay, okay, sir.
You note
So,
down the number. Nikita and Anupriya, note down the number.
Yes.
Email ID.
so this is actually a sum tube, a double lumen tube, right? So this is put through the nostril, and where does it go? It goes into the, yes, please take the close-up of this. It goes right into the upper esophageal pouch, and it has multiple openings in it. So the drainage will occur. There's a continuous suction is applied to the port that I've marked, and continuous suctioning is done through that. And the other port is for venting. That is, you either put air or saline, just 0.5 to 1 ml to the other port to keep the tube patent. So this is used for continuous suction of the baby, right? So the name is a little difficult, Riplogal tube. Okay, next. Okay, so again, these are two X-rays I've taken, two different neonates. In one, you can see a dashed line. The arrow is pointing to that dashed line, a broken line, and in the other, the broken line is coiled. So what is this? Show the other X-ray also. Show the other X-ray also. Yes. So the other, you see, again, they're both. What is it? Anybody's answered?
Not yet, ma'am.
We'll give them some more time, 15 seconds.
Still waiting for answers.
Okay, should I answer?
Yes, ma'am, go ahead.
Okay, this is again that same Riplogal tube. I told you it has fenestrations at the lower end. So it is the same tube which you're seeing here, which is getting coiled in the esophageal pouch, right? Then the next question. Okay. So the question is, what is the most likely gross type of tracheoesophageal fistula in this? Just show the close-up first of the coil tube. Yes. This is you can see the nasogastric tube coiled up, and below is the abdomen. Now focus on the question, please. The question. Yes. What is the most likely gross type? A is C and D, B is A and B, and C is A and D.
Answers have come as option B, that is A and B.
How many have answered that?
6 people have answered. 5.
Great. We must give them a big round of applause. That means they were listening to the lecture, to the discussion. So the answer is B. Why? Because the nasogastric tube is coiled in the upper esophagus, but if you see the abdomen, it is gasless. There is no abdomen. That means there is no communication between the esophagus and the lower esophagus and trachea above. So it can either be A or B type. Because in others, I told you, C, D, and E, there is a communication which facilitates the entry of air into the abdomen, right? So it can be A, which is isolated esophageal atresia, or B, where there is atresia with proximal fistula. There is no distal fistula, no distal communication. Okay. Next. Okay. Now the question is, we have diagnosed this as F with gross B. Is it true or false?
And 2-3 people have answered it as false.
False. Have they given the reason also why it's false?
No, ma'am. Same.
If anyone could answer that, why it is false?
Because there are gastric bubbles seen. Few
Yes.
people have answered it.
Very right. Good. Because you can see gas in the abdomen. So the gas in the abdomen means there is a distal TEF, right? So this can. So if you see this figure again, A and B, there is no communication. That is why you get a gasless abdomen. Whereas in the rest of the three, there is a distal communication with the trachea and the stomach. So you will find gas in the abdomen. That is why it is not A and B. Right? Next. That is all. So now I will hand over the next part of the presentation to Dr. Medha and Dr. Raksha for the anesthetic management.
Good evening, everyone. So I will be taking this class forward along with my senior resident, Dr. Medha Shukla. Dr. Medha, please share your presentation. So now we have a neonate who is diagnosed case of tracheoesophageal fistula. He's having patent foramen ovale also. Dr. Medha, what problems will be encountered in pre-operative assessment of these such type of patients, including this patient? Will you enumerate?
Yes, ma'am. Basically, ma'am, we can have dehydration in these patients as we are not feeding them orally. Also, as a result of the same problem, they might have hypoglycemia. Also, one of the risk factor for hypoglycemia is the prematurity as well, ma'am. As we have discussed, ma'am, hypothermia is also common in premature babies as a result of less subcutaneous fat and loss of, there is no shivering mechanism in them. Also, insensible losses are there. And we are expecting electrolyte imbalances, ma'am, also. Because
Why we have electrolyte imbalances? Why will be there?
ma'am, as we have applied a continuous suction to the proximal pouch, so we will be constantly draining the secretions, which will lead to the electrolyte abnormalities, ma'am.
Okay.
So basically, we are expecting hyponatremia, hypokalemia. Also, there can be metabolic alkalosis in these patients. Other than that, ma'am, as we have discussed that these might have lung disease as well. As a result of prematurity, these patients might have respiratory distress syndrome, or because of aspiration of the contents, there may be aspiration pneumonitis also. And underlying cardiac diseases are also expected in them as the percentage association is very high with TEF patients, ma'am.
Okay. So Medha, you told me that they may have respiratory distress syndrome, they may have aspiration pneumonia. So how would you manage and optimize such patients with respiratory complications in pre-operative period? Because you cannot take the patients who is having bad chest or who is not optimized straight away to the OT, right or wrong?
No, ma'am, we cannot take. As we discussed in Waterson's classification, ma'am, patients who have a good weight without any underlying pneumonia or cardiac anomalies, they can be taken for surgery directly. Rest, if the patient is having a severe pneumonia or cardiac anomaly, that needs to be optimized in the pre-operative setting, and then only the patient can be taken for surgery.
So how can you prevent aspiration pneumonia in such patients?
Yes, ma'am. For that, ma'am, as soon as the diagnosis of the TEF is established, basically we stop the oral feeding and we put these patients on an IV drip. Dextrose-containing fluids are given. And for a continuous suctioning of the proximal pouch, a 8 or a 10 French feeding tube is kept in the proximal pouch, and a continuous or intermittent suction is applied, which will prevent the aspiration pneumonia, ma'am. Other than that, we can keep these patients in a semi-prone or a prone position, or a sitting position with supine position with 30-degree head elevated. This will also decrease the risk of aspiration.
Okay. As someone in chat asked whether the repogal tube is readily available or not. So in our setup, repogal tube is not available and it is not readily available. So what we do, we use feeding tube only for the continuous suction. So Medha, can you tell us how much suction pressure we should apply? Because you are applying a continuous suction pressure, and
Yes,
high suction pressure can damage the neonatal mucosa. So how much
yes,
suction pressure we should keep the neonate on?
Ma'am, basically we keep a low suction pressure of about -20 to -30 mmHg now.
In some cases, there are fistula also, which are very large.
Yes,
And
ma'am.
some surgeon, they do pre-operative gastrostomy for these patients. So
Yes,
what do
ma'am.
you think, is gastrostomy is recommended in all the patient for decompression?
Ma'am, basically, if we are expecting a large fistula or the patient is having severe aspiration pneumonia with atelectasis, in only those patients we use a gastrostomy tube. Other than that, another indication is if we are planning the patient for a staged repair, then we can put a gastrostomy tube and we can start feeding from there before taking up for surgery, ma'am. So it's not recommended in all the cases, ma'am.
Medha, can you tell me what are the anesthetic concerns involved in the patient which are to be operated for tracheoesophageal fistula, these small neonates?
Ma'am, one of the concern is the placement of the ETT tube. In patients who have larger fistulas, that is more than 3 mm in size, sometimes when we are ventilating the patient, it is a wasted ventilation. Most of the ventilation is passing through the fistula to the stomach. So it will lead to ineffective ventilation. Also, it will lead to gastric distension. Also, we have studied that the patient might have underlying lung disease, which will complicate our ventilation and maintaining of the saturation in the intraoperative period. Also, associated congenital abnormalities, especially cardiac anomalies, are also present in these patients, which can complicate a case a little bit. Maintaining of hemodynamics and saturation becomes difficult.
You said that prematurity is associated with respiratory distress syndrome. So if there is respiratory distress syndrome, so what we can do to optimize such patients?
Ma'am, basically, we receive these patients on oxygen. Depending upon the condition of the lung, these patients might be on a nasal prong, or they can be on a CPAP, or they can be mechanically ventilated. So these patients also, if we are suspecting aspiration or sepsis is there, we can give IV antibiotics in the preoperative period, and then we can optimize before taking for surgery.
Sometimes in premature neonates, like pediatrician, they give surfactant dose for such patient to prevent respiratory distress syndrome. Okay.
Okay.
Now, you have a patient for TEF repair. So what are your intraoperative anesthetic goals which you should keep in mind before preparing or before taking this patient to the OT and after taking to the OT?
Yes, ma'am. So as we have discussed, ma'am, adequate ventilation of the lung is one of the concern. So placement of ETT tube, basically we have to keep the tip of the ETT tube beyond the fistula so that we are not ventilating the fistula and it's not a wasted ventilation. So one of the goals is that we have to maintain ventilation without ventilating our fistula that much, which will lead to the gastric insufflation. Then maintaining of a hemodynamic instability in the intraoperative period is also another concern. As these patients, they are generally premature, we have to avoid hypothermia in these patients. They are more prone to that. We have to avoid hypoxia and hypoglycemia, hypercarbia. As a result of hypercarbia, there may be reversal of the transition circulation that may be present in these patients.
Whether your patient has patent foramen ovale also.
Yes,
So
ma'am.
what care you will take regarding this disease associated with TEF?
Ma'am, one thing is that we will avoid any kind of acidosis, hypoxia, or hypercarbia. And also we will avoid we have to be very cautious when giving drugs that no air bubbles should enter into the circulation, which can lead to embolism, air embolism.
Okay. Now you have to prepare your OT and you have to prepare your airway trolley.
Yes.
The requirement of airway equipment is different for neonate as compared to children and adults. So how will you prepare your airway trolley? You let us know.
Ma'am, basically, we have to prepare a difficult airway trolley for these patients. So we will different size of face mask, both for preterm as well as term babies. That is 00 and 0 size mask should be there. And ETT tube sizes 2.5, 3 and 3.5 should be readily available. Along with that, laryngoscope, both Miller and Macintosh blades should be there. Miller is mostly used in neonates and preterms, but few practitioners are more used to MAC blade, so it should also be available on the trolley, ma'am. If CMAC is available, it can also be kept in the airway trolley. Along with that, oral airways 00, 000, and 0 size should be available. Bougie and stillet should be available if you're expecting a difficult intubation in such patient, because some of the patients might be syndromic as well. So suction catheters should also be available, 6, 8 size, and also with a working suction should be there. Then for fixation of the ETT tube, we should have ETT fixators. Neonatal ambush should also be on the airway trolley. Along with that, we should have a air rescue device. LMA size 1 is good enough for neonates. And then if in some centers, ma'am, flexible fiber optic bronchoscopes are there. So if they are available, that should also be kept on the airway trolley.
Give me the very well elaborated, very elaborate list. Do you know what size smallest tube is available for neonates?
Ma'am, 2 size 2 mm uncuffed tube, ma'am, is also available.
Yeah, during my practice, I have done a lot of TEF patients, and anesthetized them. So many of them had subglottic stenosis. So
Yes, ma'am.
sometimes your even 2.5 size tube does not go. So you should have smallest size tube available in your OT, because they have sometimes subglottic stenosis associated also. And regarding the equipment, the blades, like the blade with which you are able to practice and you are comfortable. Like if you are able to practice and comfortable with Miller, you should use Miller first. Okay.
Yes,
And
ma'am.
all the other things, as you have mentioned, should be kept in the trolley. The use of flexible fiber optic bronchoscope is for us and for surgeons also. Sometimes surgeons, they tell us to locate the position of fistula. In that case, having a handy flexible fiber optic bronchoscope, the smallest available size like 2.2 mm ID, we can pass it through the LMA size 1. And with the help of flexible fiber optic bronchoscope, we can locate the position of fistula for surgeons. And also sometimes when the location of fistula is important for anesthetists also, because if we keep our tube above the fistula, or if sometime our tube is ventilating the fistula, then it could be of like it will have bad effect on the patient, because patient will suffer hypoxia and gastric dissection. So the role of flexible fiber optic bronchoscope is important for us as well as a surgeon. Okay. So next thing I would like to ask you, for a neonate, now you have to prepare operation theater.
Yes,
So
ma'am.
there are many things which you should take care while preparing the OT. So what consideration you will keep in your mind?
Ma'am, first thing is that the OT needs to be pre-warmed before the patient enters the OT. So basically, we keep it warm till at least it should be 28 degrees Celsius, ma'am. And then we have to make sure the acronym is SOAP-ME. So the suction, oxygen, airway equipment, positioning, monitors and medication, as well as our equipment should be handy before we are taking the patient in the operation theater, ma'am.
So all the postgraduate, they should remember the mnemonic SOAP-ME. When you go to OT, check your suction is working or not, your oxygen is there or not, your all the airway equipment required for the patient are there or not, position of the patient, optimal position. Sometimes we do use the patient, sometimes they have large head, so we do use bath towel or folded sheet under the shoulders of the patient, and check proper monitors and medication required for the patient is available and not. And how do you load the medication for a neonate? You do not use 5 ml or 2 ml syringes. So preferably make your drug in 1 ml BD insulin syringe. So that way you do not have to dilute the drugs, and you can accurately give the required dose to the patient. So that's important. And your other equipment like ETCO2 and other equipment should be in place. Medha, what sort of equipment for monitoring you will keep and check in the OT? What is the monitoring which you'd like to apply for such patients?
Ma'am, starting with the standard monitors that we apply usually in all the cases like pulse oximeter, ECG, ETCO2, then the temperature monitoring, non-invasive BP. Then depending on the case, in these patients, we use a precordial stethoscope also because correctly placing of the ETT tip is one of the concerns in such patients. And then if we are suspecting the patient is having some underlying cardiac issue, as we can see in our case, then we'll place arterial catheter as well for intraoperative monitoring of invasive BP as well as for blood gas analysis.
See, the arterial lines and central venous line, they are written in the book, but they are not indicated in all the cases. So for IV lines, 2 cannulas for the patient. And if patient is having some cardiac anomaly, then arterial line can be taken. And the precordial stethoscope, this is not used by youngsters nowadays, but let me tell you, it is very important monitoring. If you keep the precordial stethoscope in the left side of the inferior axillary line, you will be able to hear cardiac sounds, you will be able to hear respiratory sounds, and it will give you very good idea with just such a simple equipment. So always keep in practice of applying precordial stethoscope. You can stick it with your sticking tape over the chest. Now, Medha, you have nicely prepared the OT, you have decided the monitoring, you have applied the monitoring. Now, let's come to the anesthesia part. How will you ensure the correct? How will you ensure that the induction is smooth for such child? What do you will do while induction of such patient?
Ma'am, we will start with the pre-medication. We generally use glycopyrrolate, 4 mcg per kg, as there are increased secretion in these patients and risk of aspiration is high. So then we'll do a thorough suctioning of the upper pouch. The feeding tube is already in place, so we'll do a good suctioning of that. Also, we will pre-oxygenate these patients for at least 5 minutes, as there is risk of desaturation and they have low FRC and risk of desaturation. They give very less time for intubation. So we will do a good pre-oxygenation. Then, ma'am, for induction, we can use propofol along with ketamine, especially if we are expecting the patient is having sepsis or the patient is on inotropes. We cannot just alone use propofol. So we use a combination of propofol and ketamine for induction. In our setup, although books also say that we can use inhalational induction, but as the patients generally are premature, so we do not go for that in our setup, as it increases the risk of raised ICP and intraventricular hemorrhages. So we go for intravenous induction. Then we can use fentanyl, ma'am. We use a low dose of 1 mcg per kg along with a muscle relaxant. Ma'am, we use a short-acting muscle relaxant like succinylcholine, 1 milligram per kg body weight, ma'am, with or without anesthesia.
Okay. So there are many school of thoughts. Every pediatric anesthetist is practicing the anesthesia for such neonates in his or her own way. So some people, they prefer inhalational induction, some prefer IV induction, and some prefer short-acting muscle relaxants like scoline, and some prefer atracurium induction for muscle relaxation. The thing which we should keep in mind is that we do not have to give large tidal volumes to such patients. We have to always pre-oxygenate these patients to build up the reserves. If we give large tidal volume, then we will ventilate the fistula, air will go to the stomach, and when the stomach is inflated, it will push the diaphragm up and it will further reduce the functional residual capacity and the oxygen reserve of the patient. So whatever you do, you keep in mind that you are not over ventilating or you are not giving larger tidal volumes to these patients. Regarding relaxation part, should avoid awake ventilation, as you told that there is a risk of intraventricular hemorrhage in such patients because most of these patients, they are premature. So scoline can be used. I have used it in my practice, and after giving glyco till date, I have not seen any bradycardia in such patients, and no complications were seen. It achieves the relaxation in within 60 seconds, and we can intubate these patients nicely. I have also used atracurium and gently ventilated the healthy neonates. And with atracurium and gentle ventilation and with small fistula, also there was no complication. So only thing is sometimes when there are large fistulas and we are ventilating with larger tidal volume, there could be gastric insufflation, and sometimes gastric rupture can also happen. There are reports. If sometime in your career you face such situation, then you can simply put a needle through the abdomen and deflate the stomach in case of emergency, but this is very rare occurrence. Okay, and you should, as I told, you should always do bag mask ventilation, and you should prefer Jackson-Rees circuit because you have a good control in your hand. Closed circle system can also be used as per the requirement and the comfort of the anesthetizing anesthetist. So sometimes we'll move further, Midha. These days, surgical procedures, they have developed, and techniques has also been modified. Newer techniques are coming. So sometimes the surgeon, they prefer to do VATS. What do you understand by VATS?
Video assisted thoracoscopic surgery.
So video-assisted thoracoscopic repair of tracheoesophageal fistula, it is beneficial for the patient because there is minimum dissection, and there is early ligation of fistula, and it is overall beneficial for the patient in post-operative period. But is it same for us, for the anesthetist? What are the anesthetic considerations when the surgeon tells you that I want to do VATS for this patient?
Ma'am, in VATS, it becomes little difficult for ventilation also because there is collapse of the lung on one side. So maintaining of saturation becomes difficult for such cases. And also there is a risk of hypercarbia. The absorption of CO2 from the thorax will lead to hypercarbia, which can lead to reversal of shunt, which will in these patients. And there can be development of cyanosis and hypoxia.
Move your slide, Medha.
Yes.
So you rightly told that as in other surgeries, like where we can do a pneumoperitoneum or pneumothorax, so we are insufflating carbon dioxide. So what consideration we should keep in mind that the pressure should not rise more than 5 mm of Hg, because neonates, they are very susceptible to hypercarbia, and if you allow higher pressures, more of the CO2 insufflation, then there will be rebound hypercapnia, and patient may land up into acidosis, and it will delay the extubation of the patient. So you have to coordinate with surgeon nicely and keep all this consideration in your mind.
Yes.
So as I told you that you will keep fiber optic rigid bronchoscope or flexible bronchoscope in your armamentarium. So what is the role of these fiber optic bronchoscopes for TEF patients?
Ma'am, this will help in identification of the fistula before we are intubating. So it will help in placement. We'll know the length and we will know the location of the fistula. So we will be better able to place a tube. And other than that, ma'am, it will help to identify if there is a presence of any double fistula. Also, if we have done a bronchoscopy, we will know about the tracheomalacia or subglottic stenosis, which are the complications that will impair in the extubation of such patients, ma'am. And subglottic stenosis, we will have difficulty with the placement of ETT tube, ma'am.
Okay. Since you talked about ETT tube, we forgot to discuss that when we are intubating such patient. So where to put endotracheal tube depth? What is the optimum place? How much depth we should insert the endotracheal tube, and where to fix the endotracheal tube?
Ma'am, our goal is to pass the fistula. That is, we should place the tip beyond the fistula. That way, we will not be ventilating the fistula, and the risk of gastric distension is less. So to achieve that, ma'am, basically we put the tube put more depth inside so that it is endobronchial on the right side. And then we will try to take the tube out. We will just try to take the tube out till the time we are able to hear breath sounds on the left side, ma'am. That way, we will ensure that the adequate ventilation is there, and also we are not ventilating the fistula. So the goal is to go beyond the fistula and be above the carana.
Yes, Medha very correctly said that our goal is to go beyond the fistula. We do not have to ventilate the fistula, or the tip should not be above the fistula so that the fistula is ventilated. So there are many ways with which we can fix the tube. So one is, you rightly said, that we do the tube endobronchially and we keep on auscultating till the bilateral chest and air entry is equal. Another thing is, you can apply a formula which is 6 plus weight of the child. So if patient is 2 kg, then 6 plus 2 is 8. So we can fix tube at 8 and we can auscultate for the bilateral air entry. Okay. So, Medha, you have intubated this patient. Now, how will you ventilate? What will, with your ventilatory strategy, like how would you like to ventilate this patient?
Ma'am, basically we will give low tidal volumes till the ligation of the fistula. So we'll try to maintain saturation above 95% or at least around 95% with the pre-existing lung condition. So for that we give low tidal volumes and we increase the respiratory rate so as to achieve the minute ventilation, ma'am. That way we will not be giving extra volume which can lead to the gastric distension.
Yes. So we prefer to keep this patient on pressure control mode. We give small tidal volumes and we increase the respiratory rate. But sometimes this setting, which we do on the ventilator by keeping on pressure control mode and giving small tidal volume and increased respiratory rate, this is not possible on the ventilator. So sometimes we have to switch between the hand ventilation and between the ventilator depending upon the condition and the operative step of the surgeon. So we should keep all these things in mind. How would you like to maintain the anesthesia? Like what drugs and inhalation agent would you like to give for such patients for maintenance of anesthesia?
Ma'am, for maintenance, in gases we use oxygen along with air to maintain a saturation of more than 95%. And then inhalational agent, we use sevoflurane, which is a good bronchodilator as well. Along with that, muscle relaxant uses atracurium, 0.5 milligram per kg body weight as a loading dose, followed by 0.1 milligram per kg now.
Why you are avoiding nitrous in these patients? Any particular reason, Medha?
Ma'am, actually, it will further expand the gastric air and further distension will occur, ma'am.
One more reason particular to this case?
Ma'am, can cause hypoxia also, ma'am. Oh, right.
Your patient has patent foramen ovale,
Yes,
not in only child, even in adults. If there is patent foramen ovale, we avoid nitrous. So if there is any accidental air insertion, it will not expand. Okay, that would be very, very detrimental if air goes and nitrous is on. Okay. So regarding fluids, I would like to ask, because there is many confusion among all the people, like what fluid we should give intraoperatively in neonates and particularly to the patient of TEF. So would you like to tell us what fluid we should give?
Ma'am, basically we use dextrose containing isotonic fluids, ma'am. Dextrose 5% or 10% at whatever concentration the patient is maintaining blood sugar above 40 milligram per deciliter. We have to constantly keep checking the blood sugar level and have a euglycemia. Along that is to be kept at 4 ml per kg per hour rate. And also for replacement fluid, we use ringer lactate, ma'am, as it contains sodium as well as potassium. So depending upon the surgeries, it can be used from between 4 to 10 ml per kg per hour intraoperatively.
Okay, so what we do in our clinical practice, if the patient comes from the ward on 5% dextrose drip, I will continue the 5% dextrose drip. If patient comes with 10% dextrose drip from the ward, I will continue the 10% dextrose drip. we will maintain the infusion of this dextrose-containing fluid at the rate of 4 ml per kg per hour. But then we have to replace the losses, insensible losses, and ongoing losses also. So for those, we will always use isotonic fluids, which is ringal lactate or plasmalite. And because the TEF patient, they are small neonates, and the insensible loss is more, we can go up to 10 ml per kg per hour of the replacement for their insensible losses and ongoing losses. So you have to grade it between 4 to 10 ml per kg per hour, depending upon the situation, depending upon the ongoing losses, depending upon the hemodynamics of the patient. Okay. And because this patient, even the small amount of blood loss will be detrimental for them. So you should always arrange the blood and replace the blood with blood only. Okay. Plus, you have to do glucose monitoring for such patients, because if you are giving less glucose or like 5% was going, maybe the requirement is more. So you should always do intraoperative glucose monitoring for such patients.
Yes,
Okay. So now your case is going on, Medha. Intraoperatively, surgeon is ligating fistula. He's fiddling with fistula and other tissues. And you just notice some desaturation on your monitor. Your saturation dropped to around 60. So what do you think could be the reason for desaturation intraoperatively in such patients?
Yes, ma'am. Ma'am, there can be various causes for that. One of the cause being surgical retraction. So when the surgeon is retracting the tissue, it causes collapse of the lung on that side. For that, we can ask the surgeon to release some traction, and again, the oxygen saturation will build up, and then the procedure can be restarted again, ma'am. Other causes that can be there are as a result of, there may be tube blockage as well,
Maybe a
ma'am.
slide also, Medha.
Ma'am, then the other causes that can be there are there can be kinking of the ETT tube. So we have to see the whole circuit, whether there is any disconnection or there is kinking of the tube is there. So we have to release that. Ma'am, then also there can be some blockage of the tube as a result of mucus plug or as a result of blood from the surgical repair, ma'am. So we have to do a thorough suctioning of the ETT tube. Other cause can be, there might be migration of the tube also, ma'am. So during the retraction process and the change in the position, there can be migration of the tube, and we might be ventilating the fistula, as a result of which we are unable to maintain the ventilation in such patient. For that, we need to check our precordial stethoscope for the breath sounds and also readjust the length of the ETT tube, ma'am. Ma'am, other than that, there may be intraoperative bronchospasm can also be there, ma'am, which can be managed with beta-2 agonist, ma'am, like salbutamol can be used, ma'am. Aspirin puffs can be used intraoperatively for that.
Okay, very well enumerated, Medha. Sometimes there is accidental extubations also. So you have to be very, very cautious. Since the tube size for these neonates is very small, so even the small amount of mucus plug or small amount of blood which is coming from the surgical site can block your tube, increase the resistance. So you should always anticipate such thing like blood and mucus plug in the tube and suctioning. And many a times what happen while the surgeon is doing your dissection, that time because of their retractors which are placed on the lungs, they have deflated the lung. So sometimes when the patient is desaturating and you tell the surgeon that there is desaturation, and sometimes he removes his retractor, the oxygen saturation immediately improves. So what you can do, you can tell him to remove the retractor, and you can ventilate the patient, build up the oxygen carrying capacity of the patient, build up the functional residual capacity of the patient, and then again tell the surgeon to start with the surgery. So many a time it happens that surgeon will tell you, you're not allowing me to operate, but then you have to tell them that you have to be very considerate, because this is for the patient only. If you allow me to ventilate for some times, I will build the reserve, then you can operate. So it is always like your coordination and surgeon's coordination in such conditions. Plus the other conditions which you told, we have to keep them in mind, because hypoxia can be detrimental if you do not suspect them on time. Another thing I would like to tell you, like sometimes there is bradycardia first. So most common cause of bradycardia in neonate is hypoxia. So if you correct the hypoxia, you will correct bradycardia automatically. So don't every time jump your hand on the atropine. When it is required, you should keep your hand on the pulse. Check for the your skin for capillary refill time. And if the hypoxia, the reason of hypoxia is known to you, correct the reason of hypoxia, your bradycardia will automatically correct.
Yes, ma'am.
Okay, Megan, no, tell me, like this patient, surgeon is cutting on them, they will be having pain. So what do you
Yes,
have
ma'am.
in your mind for the pain management for such patients?
Ma'am, basically, we can go for medical management as well as we can go for the blocks. In medical management, we can use fentanyl, 1 microgram per kg. But if we are planning, this is the low dose of fentanyl, we can use a higher dose if we are planning not to extubate the patient and the patient needs post-operative mechanical ventilation, then we can use a higher dose of opioid as well. Ma'am, other than that, we can use acetaminophen. IV dose is in these patients is around 7.5 milligram per kg. A lower dose is used as a result of not properly the enzymes, liver enzymes are not developed in these patients. Then the rectal dose of acetaminophen is 15 milligram per kg. So we can use a rectal suppository of acetaminophen as well, ma'am. So, ma'am, this is the medical management. Other than that, we can go for regional techniques also. But the most commonly, the most widely used is caudal epidural catheter. But before taking up the patient for caudal epidural catheter, we need to get a lumbar ultrasound done in these patients, especially if there is a sacral dimple present. So we can rule out the spina bifida. I mean, don't injure the spinal nerves in any case, ma'am. So, ma'am, basically, the patients who are premature, it is recommended that if the post-conception age is less than 60 weeks, then regional techniques is recommended in these patients to prevent the post-operative apnea in such patients, ma'am. We can use bupivacaine infusions via the caudal epidural catheter at the rate of 0.2 milligram per kg per hour. Then, other than the caudal epidural catheter placement, other techniques are paravertebral block, ma'am, or intercostal blocks can be given, or local infiltration can also be given by the surgeon, ma'am.
Okay. So to my experience, like medical management we are doing, we should keep fentanyl to the lower side only, like 1 microgram per kg body weight. We should obviously give multimodal analgesia to the patient. We should give paracetamol injection, or if not, we can put the your suppository through the anus, and substitute with the regional techniques. What I would recommend that give local infiltration and intercostal block in each and every case. And the advanced technique which are mentioned in literature, yes, people are practicing. I myself have practiced caudal epidural catheter threading. But when you are threading the catheter through the caudal epidural space, you're not sure that catheter is reaching to the appropriate points. Then you have to take help of the fluoroscopy to see whether it has reached to the appropriate place or not.
Yes.
And regarding paravertebral block, yes, it can be done ultrasound guided. Then, again, it needs very expert hand to place paravertebral block. Intercostal nerve block, you can tell surgeon only when the thorax is open and he's about to close. Then at that time only you can make him load the local anesthetic and tell him to give intercostal nerve block. And obviously local infiltration should be given, keeping in mind the toxic dose for the neonates. No, you have managed case well. You have given analgesia also. Now, sometimes there is always a dilemma whether to extubate the patient on table or should we ventilate such cases. Sometimes surgeon only say, अरे don't extubate this patient, इसको ventilate होने दो, फिर थोड़ा ठीक हो जाएगा, उसके बाद उसका fistula वगैरह बंद किया अभी repair थोड़ा ठीक हो जाएगा, उसके बाद extubate करना. So what do you think that you should extubate on table or should we ventilate? What is your say?
Ma'am, basically, it will depend upon the condition of the baby, his pre-operative status as well, ma'am. If the patient, we have received the patient on mechanical ventilation, So the underlying cause, the pneumonia or sepsis, has to be there for the mechanical ventilation. So these patients might require post-operative ventilation also, ma'am. And if there is a major cardiac anomaly also, then also we would not rush into the extubation process. We would like to mechanically ventilate these patients and slowly wean them off the ventilator, ma'am. Sometimes, ma'am, surgeons want us to keep the patient for mechanical ventilation, especially when the anastomosis is under tension. So there is a risk of leakage of the this anastomosis. In that cases also, surgeons, they recommend that we should keep the patient ventilated in the post-operative setting, ma'am. And also sometimes once we have extubated the patient, but suddenly the patient started desaturating, one of the cause for that can be tracheomalacia, ma'am. So if you're expecting the patient is having tracheomalacia, we need to reintubate such patients. And these patients would require a long-term mechanical ventilation, ma'am. So we would keep them intubated, ma'am.
Okay. So in my practice, if we have taken healthy neonate with good birth weight, with no preoperative chest complication, and if the surgery went well, we will extubate on the table. If patient has already was on mechanical ventilation, then obviously I will not attempt the extubation on the table. I will shift the patient for ventilation, let him improve, and then we will extubate. And the thing we should learn, listen to surgeon sometime also, because surgeon, the thing that he's saying that my anastomosis is under tension, he's right on his side. So if he's saying that he requires mechanical ventilation because he needs some support for anastomosis to heal, we should listen to surgeon also. And because it is a collaborative approach, combined effort, so we'll decide combinedly, and accordingly we will extubate on the table or shift the patient on ventilator. But for extubating on the table, you should remember that there should be no hypothermia. Patient should not be in hypotension. Temperature should be normal. Electrolytes should be normal. There should be no major blood loss. And because even if there is major blood loss and you have replaced the blood, the oxygen carrying capacity does not come within how many hours?
Ma'am, 1 hour, I'm not sure, ma'am.
So anybody want to reply in chat box how much time it takes oxygen carrying capacity to build after a transfusion? Nobody has replied. Can you check, please, coordinators?
Nobody has replied yet, ma'am. 6
No,
hours.
not 6 hours, not 6 hours.
24 hours.
Any more guesses?
One student has answered 8.
No. Come on, PGs. It's okay, they can reply me by the end of the class. I'm not telling. I want them to read a bit more. So we will move further. So what are the complications in post-operative period that can occur? Because we have a repair done from surgeon. So there will be many anticipated immediate complications as well as some late complications. So Medha, what are the immediate and late complications which we should anticipate after the repair is done?
Yes, ma'am. Ma'am, after we have extubated the patient, there might be bronchospasm as there has been fiddling with the airway, and also these babies, they have a they have reactive airways as a result of underlying lung disease. So while extubation, we may encounter bronchospasm, or there may be associated stridor as well if we are extubating. Also, as we have discussed, ma'am, if the patient is having tracheomalacia, so it will suddenly will lose the airway and patients will start desaturating. So in these cases, we need to reintubate the patient immediately after extubation, ma'am. Also, there can be injury to the recurrent laryngeal nerve during dissection, which can lead to vocal cord paralysis and which can lead to respiratory distress, ma'am. So these are the early complication in the immediate post-operative period. Other than that, there are certain late complication, like there can be anastomotic leak or there may be formation of a stricture there. Then these patients may long-term have a gastroesophageal reflux and also esophageal dysmotility may be there. Also, such patients are more prone to recurrent infection and the reoccurrence of tracheoesophageal fistula has also been seen in the post-operative period.
Okay, as an anesthetist, I'm obviously concerned with all the early postoperative complications and we have to manage them. Regarding tracheomalacia, if tracheomalacia is already present, then after the extubation, immediately we will need re-intubation for the patient because the mucosa will fall on the interior wall and patient will not be able to breathe. So this complication, although it's very rare, but we have to keep it in mind. In that case, we may need long-term ventilation for such neonates. Regarding late post-operative complication, what I am worried about is anyone from PGs online who are watching our class? No answer?
No answer. Ma'am, can you repeat the question? Maybe we'll get more
Yes.
yeses then.
I'm saying that being an anesthetist, I am worried about all the early complications because I will face them immediately after extubation. Regarding late complications, is there any complication among listed one which you are worried? So if the patient will have an ostomotic leak, again, the surgeon will bring that patient to me for anesthesia. So I'm worried that patient should not have any anastomotic leak in the delayed complication. Okay. And regarding our question, which we said that how much time it takes oxygen carrying capacity to rebuild. So we have 2-3 DPG depleted in the blood, which is being transfused. So 2-3 DPG shifts the curve towards left. Hemoglobin dissociation curve. Every PG should know hemoglobin dissociation curve and the factors which are shifting the curves toward the right and to the left. So when the curve is shifted to left, so there will be decreased oxygen unloading. Okay. So because there is no 2-3 DPG in the transfused blood, it will take some time to replenish the 2-3 DPG store, which will eventually shift your oxygen hemoglobin dissociation curve to right and start unloading your oxygen. Then it will take around 12 to 24 hours for replenishing the 2-3 DPG. So if there is massive blood loss in such patients, they will not be able to maintain their oxygenation if lungs are also bad. So in that case also, you will ventilate such patients. Okay. Now I will ask few questions to PGs to check how much attentive they was in our class. So Nikita, will you check the inbox for answer while I ask questions?
Sure, ma'am.
Okay, so tell us the ideal preoperative preparation for neonates with TEF includes immediate surgery without any preparation, keeping the neonate nilparolar and aspiration of the upper pouch and head elevation, routine feeding with breast milk or placing a nasogastric tube and starting enteral nutrition. What you will do?
Majority are answering option B.
Okay, very nice, correct. So they know that now this neonate has to be kept nil per oral in preoperative and has to be put on aspiration. Can you tell me how much continuous pressure we will apply with the feeding tube which you are using for aspiration? Dr. Mehta told how much pressure to be applied. Any answers?
20, 20, minus 20 to 30, 25 to 30, 10.
Okay, so
Multiple
the
answers
answer
are
is
coming out.
20 to 25 centimeter of mercury. Okay. Okay. Now, can you identify this X-ray? What you can see? I have not given any options because then you will easily guess. Can you guess without options? Any answer?
No answer yet, ma'am. Waiting.
No answer. Okay, I will tell you this is some blind pouch.
Yes, a
Hint.
student has answered blind esophageal pouch.
But what is inside that pouch?
Dye.
Dye, yes. It could be barium sulfate or it could be gastrographene. So this is the investigation which is done to diagnose the blind pouch. Okay, this is esophagogram. So in case there is fistula from esophagus to trachea, can you tell me which fistula is communicating esophagus and trachea? Which type of fistula is communicating? In which type of fistula is communicating with trachea?
H.
Esophagus.
H type.
H
Yes,
type.
everyone are answering H.
Is B not communicating? Is E not communicating? So in case there is communication, this dye can go to lungs also. Okay, through trachea. Okay, next question. Which of the following is the best approach for endotracheal tube placement in TEF surgery? You will place your tube A above the fistula, below the fistula, at the level of fistula, or you will place it in the esophagus to block the fistula.
Everyone have confidently answered option B.
I'm very happy. Okay, moving to next question. So, what is the preferred ventilatory strategy for the intraoperative management of TEF repair? You will do spontaneous ventilation throughout the surgery. You will put the patient on controlled ventilation with minimal peak inspiratory pressure. You will put the patient on high PEEP and high tidal volume ventilation, or you will hyperventilate the patient to maintain hypocapnia.
Strong replies on option B.
Very nice. Okay, next question. Which post-operative complication is commonly associated with TEF repair? Myocardial infarction, tracheomalacia, renal failure, or hypertension?
Again, everyone are answering option B.
I
Tracheomalacia.
think I have put very, very easy questions. Everyone is answering. Okay. So, which syndrome is associated with tracheoesophageal fistula? A. Charge syndrome. B. Which is the most commonly associated with TEF? Charge, Vectral, Pyrorobin, or Prader-Willi syndrome?
Even before the question was we're giving B. More answers B.
Okay, nice. Which is the intraoperative monitoring, which is very, very essential during TEF repair? Bicep spectral index monitoring, neuromuscular monitoring, and tidal carbon dioxide and precordial stethoscope, or intraoperative EEG?
Everyone are giving option C, ma'am. End-tidal carbon dioxide and precordial.
So I hope everyone will keep ETCO2 and precordial stethoscope whenever they are operating TEF patients. And that's all from our side. We are happy to answer any questions or any doubts if anyone among the audience want to ask.
Can I add something?
Yes, ma'am.
Excellent presentation, Dr. Raksha and Dr. Medha. It was really very enlightening. So one thing I would like to say is if the fistula, if you're ventilating and supposing you're again and again you're ventilating the fistula. So there are certain, okay, this picture. Okay, first let's go to this picture. This picture I purposely put because Dr. Bajwa wanted this. picture. So I want the PGs to identify what is this round metallic piece. So somebody has answered.
Precordial stethoscope.
Good. So let them answer. What is the difference? What are the properties of this precordial stethoscope? Can anyone answer? So it has a big diaphragm, it has a longer tubing, and it is monooral. What does monooral mean? Anyone?
One earpiece.
With your only one ear also, you can get a good quality. It is a good quality sound you can get with one, putting the piece in the one ear only, right? Then one more thing I wanted to say. So if the fistula is, say, pericarinal, and it is difficult again and again, when you are insufflating the fistula. So what you can do is, as Dr. Medha said, one of the ways is that you put the tube into the bronchus on the right side or right side is easier. So you put the tube in the right side, auscultate on the left side, and gradually and slowly you withdraw it millimeter by millimeter till you hear the sound on the left side. Then another method is that you insert the tube and then rotate it 90 degrees. So that the bevel faces anteriorly, because you'll have a longer shaft. Most of the fistulas, they are posterior. So you will have the length of the shaft, which will be acting like a door to the fistula. So ventilation will become easier. So insert and rotate anteriorly so that the bevel faces anteriorly. Then another method to check how you can do it, if you have a gastrostomy tube, then you open the gastrostomy tube, put it in the water, and you go on progressing the tube. So till you are above the fistula, the fistula will be ventilated and you will see the air bubbles in the water. But once you pass the fistula, the bubbles will stop. So that is the point where you have to fix your tube. And another important thing is that in these patients, Ryle's tube positioning and fixation is very important, because if it goes out, reinsertion is not an option at all. You cannot reinsert it back, because otherwise you'll cause an anastomotic leak. So that is why a proper fixation of the Ryle's tube is very, very important in these patients.
Surgeon, they don't trust us. Sometimes they take a stitch on their tube and secure it. So they are more worried about the tube, and they are more enthused about it. No, I have to fix it with a suture only.
And during the surgery also, so many times they ask us to put in a red rubber tube. If they cannot identify the upper end of the esophagus, they ask us to put in a red rubber tube, move it back and forth for the identification of the upper blind esophageal pouch. That is also done so many times.
And sometimes while we move this red rubber tube in and out, sometimes it results into extubations also. So we should be very careful while we are doing such maneuvers so that our tube does not get out. And we have to be very vigilant when you are doing such maneuvers.
Ma'am, a student has requested if you can explain again the water bubble method for ET tube insertion.
See, what happens is that if the fistula, if your tube is going down, right, and your tube is above the fistula, it's a large fistula, the tube is above the fistula. So the gastrostomy tube is there. So you are ventilating the fistula, right? The air is going into the fistula, and through that it is going into the gastrostomy tube, and you are getting bubbles in the underwater seal. So once you pass the fistula, now you'll be ventilating the lungs. So the air bubbles will stop. Have you understood? Is it clear?
Yes.
Okay.
Ma'am, there is a query. Is there any role of preductal and postductal SpO2 in this case scenario?
There is a role. So that is why we put 2, because there are cardiac anomalies in these patients. And so many times, even if we don't find any congenital anomaly, still for these patients, you must have a preductal and a postductal saturation, because so many anomalies, they go undiagnosed. And if you want to really see how you infer from this is if the difference in the saturation in the pre-ductal and the post-ductal is more than 3%, then that means there is significant right to left shunting.
Nikita, any more questions in chat box?
No, ma'am. If any of the students have any more queries, they can share it now.
Yeah, I have a query. I have a student, so just want one query to the both to the Meda and Tabia, Taiba. See, how many times you have done the post-operative round in a case of esophageal fistula? Post-operative rounds taking care of the patient. Keep a hand on your heart and tell the answer. How many times you have done? You must have done many cases, I think. Now, here the question comes of the trusting the surgeon, whether we don't trust the surgeon, don't trust us. Do you think that these pediatric surgeons, they take care of their patients in the neonatal ICU? And here we don't pay attention to these patients post-operatively because we talk about so many complications. There people are looking at those patients. They are very well versed. I think all the pediatric surgeon, majority of them are very well versed with the mechanical ventilation pattern, the T-tube pattern, or whatever the intubated patient. They manage it very well. So it's a one of the specialty where surgeons have a very diverse role, right from the pre-operative, intraoperative, and post-operative. We are more concerned with the intraoperative, or the topic was the perioperative. You go to the neonatal ICU, you see the patients are always managed very well by these surgeons, pediatric surgeons. Now, regarding that extubation, even in if you go with the normal life mechanisms, whether the patient was healthy or a patient was having some pre-existing comorbidities or some lung disease, it's always recommended to put the patient on tube and shift the patient to the neonatal ICU. The reason being back is not that every surgeon is a good surgeon, how much the edema they must have caused to the tracheal rings and tracheal mucosa, tracheal structures. And moreover, the tracheal rings are also not that well developed that they will be giving support to the trachea, to the patency of trachea. Invariably, these are the genetic congenital abnormalities, so that you expect that the muscle power of the trachea may not be the even the deficient space of the posterior from the anterior posterior part of trachea, it can collapse. So whether the patient was healthy or not, but it has been manipulated by a different type of surgeon with a different level of surgical inserts. So it's always better so that the edema around the tracheal muscle, the tracheal structure gets reduced to a good extent so that the patient may be able to breathe. So there is no harm in keeping the endotracheal tube till the patient gets all type of homeostatic milieu, this trachea also functioning properly. So it's always advisable whether we have got working in the one of the best centers or with a resource limited center. It is always advisable to shift the patient on T2 because the pediatric surgeon, they will also feel very comfortable because at night you can't, majority of the surgeries are done in the daytime and the majority of the complications occur in the night. So it's always better if 24 hours you keep the patient intubated and then you remove the tube. You can put on the TPs, you can put on the oxygen. That's spontaneous ventilation also you can put. So that is my advice to the all the PG student. At least when you do such cases, do give the post-operative rounds. You will come to know many complications. Just intraoperative, you may not face because you are very vigilant. But in the post-operative, the vigilant staff is replaced by the vigilant doctors of anesthesia are replaced by the just staff. Majority, maybe the very high-tech staff, high-quality staff, but the post-operative period is very stormy sometimes. So either some anesthesiologist must be there, intensivist must be there doing the duty in the neonatal ICU, which many of the ICUs don't have actually. It's only we are giving, taking care of the adult ICUs mainly. And we think pediatricians we should take, but pediatricians are not, perioperative physicians. So the onus is on us people and pediatric surgeons. So this is my take on over the years, the last 3 decades of anesthesia practice.
Very nicely said, sir. We should always take care of the patient and we should keep in mind the safety of the patient first before doing any heroic extubations.
Yeah, we should not be adventurous or something. We are not working for the glory because the neonate may not be able to sustain themselves. They're totally dependent upon you because this is one of the congenital abnormality which has got a very good surgical prognosis if done properly, provided the infections are not there, bring and the patient is brought in a timely manner to the operation theater. And I feel I really give marks to the pediatric surgeons also. They've managed their cases very well post-operatively. I've seen many of the dedicated pediatric surgeons managing everything in the neonatal ICU post-operatively.
So my husband is pediatric surgeon and he will intentionally take me to the rounds along with him कि तुमने patient कराया चल के देखो.
So that means we should be giving a post-operative
Yes.
rounds regularly. That is very important in such surgeries. Anyone want to ask something? They can always ask. So you will be keep getting compliments, all of you. So that is always done because this is the one case which you always get, in the theory part, you always get either short note or sometime a long question. Dr. Madhuri want to add something.
Excellent presentation, Dr. Renu ma'am and Dr. Raksha. You have really meticulously covered almost all aspects of a TO fistula repair. Just wanted to add that just as Sir said, intensive care unit management post-op is very, very important in such cases. And so also the pain relief, I feel, is also very, very important. Because unless and until the pain relief is good, the neonate is not going to breathe well. And that is going to lead to complications. And so we should not neglect the post-operative pain management part, which you have already described. And one more thing is the azygos vein preservation. I don't know whether you all told about it, but the azygos vein is either preserved or it is ligated. So it is ligated to gain access to the fistula. But there are two ways, like if it is preserved, whether to preserve it or whether to, ligate it. So when it is ligated, what happens? The drainage of the mediastinum is impaired. And then there will be bronchial edema and the anastomotic leaks and all will be very high. So they often do the occlusion test intraoperatively and then they go for azygos vein preservation or ligation, whatever. And they say that preservation is better. Preservation of the azygos vein.
Yeah, it's time to felicitate our faculty also. The screen visible? Dr. Madhuri, is visible?
Yes, sir.
Yeah,
But
yeah.
something black is seen on top. Yeah.
Now,
Yeah, see.
what?
Clear.
Okay.
Thank you,
So,
sir.
Dr. Renu Vakluman, thank you very much.
Thank you so much.
You being the team leader for this special class and done in the pediatric neonatal. Another important case discussion. Thank you very much for anchoring this class.
Thank you, sir, for giving us the opportunity. Thank you so much.
Yeah. Similarly, Dr. Raksha Kundal took all the efforts to prepare everyone, including the senior resident also. So, Dr. Raksha, thank you for being the teacher in this class.
Thank you so much, sir.
And Meda, see, your enthusiasm in telling the management of this case was excellent. You covered almost every point, so there were minimal questions on the management side. Thank
Thank
you
you
very
so much, sir, for giving me this opportunity, sir.
And Dr. Taiba Aklak, she, in spite of having the Eid yesterday, she was still preparing properly for the
Thank you,
class.
sir.
Thank you,
Thank
Taiba.
you, ma'am, and thank you to Renu ma'am for giving me the opportunity, and thank you to you, sir, for this
No, no,
platform to speak.
you have been recorded in the national class, which will be available on the YouTube at ISNHQ. So it will be visible to everyone after this class is over. And Nikita, you are very good in anchoring, so did a wonderful job. So thank
Thank you,
you
sir.
very much for that. And same goes for Anupriya also.
Thank
You
you,
both
sir.
were very good in conducting the class as a screen coordinators. And I'm thankful to the team of Dr. Madhuri, Dr. Nishant, Dr. Ridhima also, because they always are the people behind in preparing the classes. So it should go very smoothly. Thank you very much to all of you. Before shifting, I think moving, anybody wants to add something, then you can add. We have got 2-3 minutes with us.
I think there is one more point there by Dr. Lalit Kumar Raiger. Some words on shifting to ward after ICU. That is also very important.
Yeah, basically the transportation is the same thing. I think anesthesiologist, the way we were discussing, we have to improve ourselves, our services, right from the operative area to the post-operative round. We take so much pride in calling us the peri-operative physician, but I think the peri-operative period is a post-operative period, it covers every period. So giving a care in the post-operative period is as good as giving into the intraoperative period. Transportation, I think if an anesthesiologist is there in the transportation, you can take the best care of a patient. You don't depend upon the technicians or the JRs or the PG students. I think rather a consultant, if going with the patient or a third year PG students even, that is the best way to shift a patient to the ward. Because many times during shifting only accidental extubation or some other complication then develop. So it's always nice and safe. Dr. Lalit always gives a very gem of the points wisdom because over the years he has learned so much and is sharing his knowledge with us now. Thank you, Lalit sir, for all those things.
Sir, one just thing what I wanted to ask Dr. Akshay. Dr. Akshay, are you practicing bronchoscopic evaluation of the fistula before surgery or during surgery?
Not every time, but when surgeons tell us that we want to see fistula and he suspect large fistula, only then we practice. But in routinely, we are not practicing.
I think we have got now newer investigations, NORA, where you go with the MRI or with the radiological findings, you can get the exact location,
Yes, sir.
exact size, that functionally you get exact size rather than in a structural way, not in the functional manner. But I think post-operative, how the trachea behaves, how the airway and esophagus behave, because in the vicinity of that mediastinum, so much of the surgical insult occurs. So I think the edema in the first 24 hours is very, very crucial for such patients. If they passes peacefully, the patient recovers very well. We have seen so much a good prognosis with good surgical hands and good surgical, procedure, along with the no way, the good anesthesiologist. 90% of the anesthesiologists are good anesthesiologists only when they are handling these things. So at least we can't say 100%, but I'm saying 90%. Yeah, Renu madam want to say something?
So I said 99%.
I
Ma'am,
would
see,
also say 99%.
overpraising our specialty, then you are leaving a very little margin. So in the research academics, we always give at least 5% error. So at least a 95, the power of 80% to 95 with a confidence interval. So that's what I'm saying. Madam Shobha, as usual, want to convey something, ma'am? You want to convey? You have to unmute yourself.
Seen a patient of getting operated to fistula, but can you just show the position, or if you have some video, like how short video or the position, the slide of position, what patient position the patients are given, like, so we will be ready for that, any disaster which can happen.
Meda, you have one slide for position of the patient. Can you show us? And can you zoom it also?
Yes, ma'am. Ma'am, really sorry, I'm unable to zoom it.
In the screen slideshow, it will not be zoomed.
Yes, ma'am. Actually, I'm unable to zoom it.
I think a very clear enough position. Is a surgical exposure good on the from the lateral side of the chest? I think they are going and see the little bit arc position that they are giving to the so that the maximum exposure occurs. That the ribs they are expanded with the muscle taut, so you can get the maximum exposure. A very good position. I think this is a common position we are always.
How long such procedure takes, randomly?
Pardon, madam?
How long this procedure takes? I mean, surgeon takes a random, like, the duration of the time. How long do they take generally?
Depends
Ma'am,
on
it
some
depends.
surgeons. Yeah, Dr. Raksha, please.
Sir,
You were saying.
answer please.
Yeah.
So depending upon the expertise of the surgeon, some takes 1.5 hours, some takes 2 hours, some even take 4 hours, ma'am. And depending upon the complexity of the surgery, so it varies upon the expertise of the surgeon and as well as the complexity of the surgery. It may take 1.5 hour to 4 hours, ma'am.
And also depend upon the learning of the surgeon. I think a very good surgeon, they just take around 1 hour to 2 hours maximum. And if you go with the new surgeon, sometimes the people was just passing out after from the MCH. They start doing it, maybe 3 to 4 hours they can take easily. That's the right answer actually. With a good surgeon, I've seen it very, very fast. Very, very fast. So I think it's 8:30
Yeah.
and
One of the best presentation I have learned, like I have not been come across in my practice, but whatever I have gained the knowledge out of this, obviously if the case arises, then I'll be prepared for it. Thank you.
okay, ma'am. Dr. Madhuri again want to add something.
Yeah, just coming to that position, as madam was asking about the position. So the lateral decubitus position is given na, to the neonate for surgery. So this position, the physiology, knowing the physiology of this position is very important. And this is different in neonates compared to older children and adults. So that has to be understood clearly. So the differences, especially because the dependent lung can, it can collapse at even a normal tidal volume breathing, and the non-dependent lung can be even preferentially ventilated, especially because the rib cage is very soft. So in neonates, so the dependent lung does not have increased blood flow, which is seen in is not which is there in adults is not seen in neonates.
Yeah, moreover, the dependent lung is not being pressed by the heavy structures.
Yeah,
It's the lung is very compliant, the ribs are compliant, and rib cage is compliant.
correct. So
So
the
I think that is
so
a very protective mechanism for
yes,
the.
yes, yes. So the increase in perfusion to the dependent lung, which is seen in adults, is less in neonates.
So fine, I think it was a good class. Now time to break up till we meet in the next class. So thank you, team Jammu, GMC and AIMS, and respective faculties and presenters, and all the delegates and as well as the audience. See you next time in the next class. Till then, we say good night and